Neurology Quiz number 117. Describe the pathophysiology, clinical features, investigations, and treatment of McArdle's disease. McArdle's disease is also known as glycogen storage disorder, GSD type 5. It is an autosomal recessive metabolic disorder primarily affecting skeletal muscle. It is due to mutations in the muscle glycogen phosphorylase or PGYM gene on chromosome 11. This leads to deficiency of the myophosphorylase enzyme. The enzyme normally breaks down muscle glycogen into glucose, which is the principal energy source for muscle. Pathophysiology: deficiency of this enzyme results in inability to break down glycogen in the muscle and leads to glycogen accumulation in muscles. Normally, in the first few minutes of intense exercise, myophosphorylase cleaves glucose 1-phosphate from glycogen. Glucose 1-phosphate forms the initial substrate for glycolysis. With deficiency of this enzyme, the release of glucose from the muscle is blocked and impairs glycolysis. This figure shows the process of glycolysis in the muscle. Normally, myophosphorylase cleaves glucose 1-phosphate from glycogen, which then enters the glycolytic pathway, generating ATP and pyruvate. Under anaerobic conditions in the exercising muscle, pyruvate is converted to lactate. With deficiency of myophosphorylase, glucose 1-phosphate cannot be generated, leading to impairment of glycolysis. With decreased production of ATP and pyruvate, decreased production of pyruvate in turn decreases lactate production. Clinical features: the exact prevalence of McArdle's disease is unknown and ranges from 1 in 50,000 to 1 in 200,000 in the US. It is the most common disorder of skeletal muscle carbohydrate metabolism. The disease typically presents in childhood or adolescence, but adult onset cases can occur. Although most patients have symptoms before age 15, many cases are diagnosed after age 30. Patients typically exhibit symptoms in response to sudden and intense exercise. The cardinal symptom is exercise intolerance with early fatigue, myalgia, and disproportionate dyspnea and tachycardia. This can be followed by muscle cramps, weakness, and painful contractures. The contracture is also referred to as a true contracture. It is due to impaired energy production in the muscle, leading to inability of the muscle to relax. Unlike muscle cramps, it can be prolonged and last minutes to hours, and it is electrically silent. Symptoms are most pronounced soon after starting activity and are relieved by stopping exercise. Muscle activity may be associated with rhabdomyolysis and myoglobinuria, with subsequent acute renal failure. More than 90% of patients have significant elevation of CPK during acute exacerbations, and 50% have myoglobinuria. A unique feature is the second wind phenomenon, which is characterized by improved symptoms after 7 to 10 minutes of gentle aerobic exercise. This occurs as the cardiovascular system increases blood flow to the muscles with continued low-intensity exercise. Subsequently, muscles rely more on oxidative metabolism, using blood-borne glucose and free fatty acids as alternative energy sources, with improved exercise tolerance. In one large series, nearly 50% of patients had persistent muscle weakness. CPK may also remain elevated between attacks. Some patients can experience progressive muscular weakness, especially in the 6th or 7th decade. Examination can reveal proximal muscle weakness during exercise. Fixed proximal muscle weakness and wasting may occur. This figure shows a patient with McArdle's disease with atrophy and weakness of the proximal upper extremity muscles. Evaluation: CPK levels. Marked elevation of CPK levels is seen during acute episodes. However, elevated CPK is also noted between acute episodes and ranges from 5 to 18 times the upper limit of normal. Forearm exercise test. In this, the patient performs isometric forearm exercise such as squeezing a hand grip dynamometer. A common protocol involves sustaining 70% of the maximum voluntary contraction for 30 seconds. Serial blood samples are collected at baseline and at timed intervals after the exercise to measure lactate and ammonia levels. At least a threefold rise in lactate and ammonia following exercise is seen normally, but the lactate elevation is markedly reduced or absent in patients with McArdle's disease. Failure of both lactate and ammonia to rise is indicative of inadequate exercise. Muscle biopsy can be performed and demonstrates PAS-positive glycogen vacuoles and absence of myophosphorylase. Genetic testing. The diagnosis is confirmed by gene testing showing mutation in the PYGM gene. The most common mutation is the PR50X variant. This is a muscle biopsy from a patient with McArdle's disease showing subsarcolemmal glycogen deposition demonstrated by PAS staining. This is a muscle biopsy from a patient with McArdle's disease stained with H&E showing several subsarcolemmal vacuoles indicating glycogen deposition, and these are present in almost all the muscle fibers. This is a muscle biopsy from a patient with McArdle's disease showing complete loss of myophosphorylase activity in the patient's muscle biopsy on the left. On the right is the muscle biopsy of a healthy control showing a positive myophosphorylase reaction. Differential diagnosis includes other glycogen storage disorders, fatty acid oxidation defects, and mitochondrial myopathies. McArdle's disease manifests at the onset of rigorous physical activity. Fatty acid oxidation defects and mitochondrial myopathies manifest later after longer duration of exercise. The second wind phenomenon and a positive forearm exercise test are not seen in other disorders. Patients with McArdle's disease typically have elevated CPK between attacks, which may or may not occur in the other conditions. In fatty acid oxidation disorders, attacks are often provoked by fasting and infection. Treatment. There is no curative treatment for myophosphorylase deficiency. Patients with this condition should maintain a good level of cardiovascular fitness, but should avoid intense exercise such as weightlifting or sprinting. Any exercise should be preceded by 5 to 15 minutes of warm-up to promote the second wind metabolic transition. Sucrose administration has been tried in an attempt to bypass the metabolic block. In some studies, ingestion of 37 to 75 grams of sucrose prior to exercise has been shown to be beneficial in improving exercise tolerance. The beneficial effect is short-lived, and repeated dosing may lead to weight gain. Administration of creatine and a high-protein diet have not shown consistent benefit. Prognosis. Most patients with McArdle's disease lead a normal life and life expectancy is not affected. Rhabdomyolysis is to be avoided as it can lead to acute renal failure, which could be life-threatening. Many patients learn to exploit the second wind phenomenon and adjust to the disease itself. Only a minority of patients have been known to experience progressive proximal muscle weakness and wasting with advancing age.